In long-term care, why are we talking about this in long-term care? Well, long-term care patients with heart failure tend to be less likely to receive those recommended therapies, but the concerns that are cited by the prescribing physicians are quite valid. Multiple comorbidities, what's the point? Adverse drug reaction risk goes fairly high. The issue of generalizability, is that evidence really applicable to my patient? Well, not the main trials, but some of the smaller ones, sure. And again, this atypical syndrome, atypical presentation issue rears its ugly head again. It's hard to pick it up because they don't present with the classical symptoms. So in the community, we have heart failure management programs, which is basically approaching heart failure care from a chronic disease management perspective over the long run, using multiple disciplines working together. And in the community, these things reduce heart failure hospitalizations. They also look like they're reducing mortality as well, and quality of life goes up. How about in long-term care? Well, that's been ignored so far. We do have some odd trials in the US and Italy, and I say odd not just in the sense of uncommon, but they're very odd. Imagine a nursing home that's attached to a hospital, and the cardiologist will trundle the echocardiography machine down to the nursing home to see the patient. That doesn't happen here. So those are the models that are out there in the literature, really not applicable to Ontario, but they do show that they can help. So just going to very briefly talk about some of the work we're doing. Some of you may be familiar with it, but I hope that in the next couple of years we'll have some data that we can come knocking on your doors and see, could we try this out in your home? So basically, we're looking at developing optimal heart failure management programs for long-term care based in the Ontario context, and hopefully without having to add extra resources. We want to try to get this done with what we have to work with. So we're trying to describe some of the health service issues related to this population, develop some heart failure processes for long-term care using stakeholder input, and ultimately implement a heart failure management program that we can evaluate in nursing homes. So far we've done a number of studies. The first was a lay of the land cross-sectional study. We are working on analyzing number 2, which was a very long prospective study. And then now we're in the process of doing the consultations and developing the actual intervention. So basically in our first study that was done in Hamilton, this is no news to you, but to a cardiologist this is very surprising. So real nursing home heart failure patients are about 20 years older than the ones in the clinical trials. They're mainly women. They have multiple comorbidities. Over 60% have cognitive impairment. And what we did find is the first-line drugs, ACE inhibitors, beta blockers, tend to be underprescribed, which left a lot of these folks at higher risk for adverse events from things like digoxin. They tend to be less under-investigated. Very few of them had an ECG on the chart. And to be fair, when someone gets admitted to a nursing home, you really get nothing in terms of information about this person. You're left to try to figure it out, which is a big problem. Dr. Bell. The second study basically was a prospective study. We are looking at 549 long-term care patients starting from admission to long-term care, and we are looking at up to a year what happens to these folks. And basically we're looking at function, cognition, Cohen-Mansfield, neuropsychiatric indices, and diagnostic issues. And I think one of the early things, I don't have that on a slide, but if the chart on admission says heart failure, the sensitivity and specificity of that are 90%. So if it says heart failure on the chart on admission, you can probably take that to the bank. It's not published yet, but I'm just leaking it out to the public now. So this is going to be helpful in terms of describing the natural history of heart failure in terms of its geriatric outcomes, and that will help us guide how we develop our clinical trials in the next 5 years. And finally, currently we are doing third phase, which is basically a heart and stroke funded study, where we're basically talking to providers in terms of what they think or how they think we can actually accomplish this in long-term care. The approach is not going to show up to a nursing home and say, here's how we want you to do it. We're talking to PSWs, to RPNs, to nurses, to nurse practitioners, and to doctors to try to figure out from them what are the barriers that we have to get around? What are the issues that we need to deal with in order to implement this thing effectively? So I'll skip that, but basically we've got 3 steps. We've done a survey. We are now doing a lot of focus group work, And we are going to be, in the next couple of months, putting this all together and going back to the nursing homes to finalize the product. So hopefully in the next year or so, we'll be able to have an intervention that we can pilot in a variety of nursing homes in the province. So basically, what I want to get at is heart failure obviously is a significant health issue for seniors. And if we're going to manage this appropriately in long-term care, we need to consider the geriatric syndromes as being central features of heart failure. That's how they often present. Those are the outcomes we need to be looking at. And those are the things that we need to consider when we're trying to balance how aggressive we want to be and what kind of treatments we want to apply. Heart failure-specific therapies, again, we think of all the large trials that have mortality outcomes, but they're also really effective symptom control drugs. And for most seniors, they do get benefits from using these medications. And again, the importance of a multidisciplinary approach has been shown for disease management, but the next step is we need to figure out how to do this better in long-term care. So I'll stop now.